Bismillah ar-Rahman ar-Rahim. I take great pride in welcoming all attendees to the second wave of LEAD, which stands to learn, engage, and drive IBD. IBD, as all of us know, is a disease proving day after day to be more common than predicted. At a certain time, we thought the disease was uncommon in our country and in our areas. Unfortunately, we are observing the growing evidence of a definite increase in the prevalence of such a disease. The disease has an immense impact on patients and their families, causing great social and economic burden. There are, however, many people working to fight the disease. We as physicians understand our pivotal role, yet we can never ignore the role of pharmaceuticals as Janssen, who work hard in supporting research and scientific activities as the one we are involved in now, hoping one day comes when we can announce to our patients that a cure is being possible. I welcome you all. And since we have a very busy agenda, including two very interesting talks, which will be presented by two eminent professors, Professor Ali Mosli and Professor Afify. And following these two interesting talks, there will be a practical presentation by Professor Tamer, who will be presenting the role of capsule endoscopy in GI diseases and specifically in inflammatory bowel disease. At the end of the three presentations, there will be a discussion, and I encourage all of you to share with us, and anyone who would like to ask a question, kindly use the Q&A box, and by the end of the presentation, we will be having the discussion through which we will try our best to answer most of these questions. And since we don't want to run short of our time, and as you see that we have a very busy agenda, I would like to start by introducing Professor Mahmoud Al-Mosli, who is an assistant professor of medicine and a consultant gastroenterologist. He's an IBD specialist at King Abdulaziz University at Jeddah. He has a lot of publications in the field, but maybe one of the most outstanding was on the development of patient-reported outcome measures for assessment of ulcerative colitis disease activity in clinical trials, which was published in a very eminent journal, which is Elementary Pharmacology. And this was as early as 2005. Professor Mosli, I have the pleasure to introduce you. He will address a very important topic, which is clinical update in treat to target in ulcerative colitis. Professor Mosli, the screen is yours.
Thank you very much, Professor Sherif. I'd like to start by thanking you and the scientific committee of this webinar for inviting me. It's always a great pleasure to participate and present with very eminent colleagues and speakers. The topic that I was tasked with talking about today is advances in treat to target therapy in ulcerative colitis. Is the screen appearing?
You have to share the screen, Professor Mahmoud.
Okay, sorry. Okay, there it is.
Yes.
So is it appearing now? Okay, perfect.
Yes, go ahead.
So let me start by first. Here I'll show my. These are my disclosures prior to starting my talk, and these are the points I'd like to discuss. So I'll start by briefly going over the evolution of ulcerative colitis treatment over time. Then we'll discuss different definitions of remission in IBD, and then go on to the concept of deep remission, which directly ties into the treat to target approach in IBD. So if you would ask me what is the most important part of evolution in IBD treatment over the past 50 years, I'd show you this slide and highlight how we have moved from following patients through very subjective measures of activity, such as relying on symptomatology, to more objective markers of inflammation that start with biochemical markers and extend to endoscopic assessment and even to deeper forms of evaluation such as histology. As we can see here, more recently in the past 5 years, we saw development of the STRIDE guidelines by the IOIBD in 2017. The most recent iteration of these recommendations recommended a treat-to-target approach in both Crohn's disease and ulcerative colitis. So for both illnesses, we rely on multiple parameters, as mentioned, going from biochemical markers that reflect biochemical remission, namely C-reactive protein in the blood and fecal calprotectin in the stool. Also endoscopically through our endoscopic evaluation to document first endoscopic response and finally mucosal healing or endoscopic remission. More recently, there has been significant interest in documenting transmural healing or remission in Crohn's disease, which is, as you know, a transmural disease that involves all layers of the bowel, and also histologic remission in both illnesses. But of course, it's more prominently used in ulcerative colitis. And we'll talk a little bit more about that in a minute. So these are the definitions of remission that we usually follow in our daily clinical practice when we follow our patients who have ulcerative colitis and Crohn's disease. And if we focus on ulcerative colitis on the left, you see how we combine both clinical remission with endoscopic remission. So clinical remission here is defined as resolution of rectal bleeding and diarrhea or altered bowel habits at the minimum of 3 months during active disease, in addition to documentation of endoscopic remission, which is defined as resolution of friability and ulceration, at least according to a flexible sigmoidoscope or a colonoscope. And here we're mainly focusing on a Mayo score of 0 at the bare minimum at 1. And this again at a 3-month interval. But the question that remains, how deep should we go with our expectations with regards to response and remission? Do we focus on symptoms that have now been linked to the patient-reported outcomes? Do we focus only on endoscopy, or do we thrive to proceed with histological healing? Of course, there has been recent publications talking about more deeper forms, and namely here we're mentioning molecular type of healing that has yet to be defined. I quote here Professor Colombo in an article that was published back in 2012. He defined deep remission as a state with little or no risk of disease. Yet have clearly characterized, but it reflects how these types of diseases that can progress with time to produce complications should be somehow halted at its beginning, and inflammation should be treated, and hopefully through that we will be able to prevent disease progression and complications. Now, this constant and progressive evolution in our endpoints of treatment in both diseases has changed with time. And as I had mentioned, we went from symptoms to endoscopy to imaging. And now the focus in all the current studies and publications is to find surrogate markers that reflect how the disease course itself can change. For example, in Crohn's disease, and I know that the talk mainly is focused on ulcerative colitis, but it's difficult to discuss ulcerative colitis without talking about Crohn's because they're very similar in many ways, although there are also significant differences. But as you can see in this meta-analysis, there's multiple studies, both randomized controlled trials and core studies, when pulled together, showed that mucosal healing has been strongly linked and associated with favorable outcomes. And here we can see how the estimate of 2.8 reflects higher odds of favorable outcome compared to absence of mucosal healing. Also, the recent data published a couple of years ago from the CALM study follow-up cohort showed that those patients that had documented mucosal healing showed very favorable outcomes after a year of documented endoscopic mucosal healing. And as you can see, when compared to those who did not have this outcome, there's a very statistically significant segregation between the two groups early on in the period of follow-up. As I had mentioned before, in Crohn's disease, there has been focus on targeting the inflammation that involves all walls of the bowel. And in this case, this is an inflammation that is presented as ulceration and can show itself as fistulae, abscesses, and loss of function. There has been recent publications that suggested that MRE and ultrasound can both be used to document this type of healing and has been associated with significant favorable outcome with time, including lack of need for surgery, no need of hospital admission, and the ability to go without therapy escalation. Then when we shift to ulcerative colitis, there's significant data and literature to suggest that endoscopic remission, and here we're talking about a Mayo endoscopic score less than or equal to 1, is associated with improved long-term outcomes. And as you can see here in this pooled data analysis, that patients that have mucosal healing, as defined by the Mayo endoscopic score, have better long-term outcome related to clinical remission, colectomy-free, duration of follow-up, and no need of steroid use during follow-up, all of which have been used as validated outcomes in such cohorts of patients. Now, the more interesting outcome that has been heavily studied over the past 5 years is histological endpoints. And I draw your attention in this table to 2 new indices that have been used to measure histological activity and thus histological healing and remission, the Robarts Histopathology Index and the Nancy Index. Of course, I had the pleasure of being part of the team that developed the RHI and therefore can attest to its validity. As you can see here, histologic healing has been defined as complete normalization of the mucosa. And although we only see this in about 1% of patients during follow-up, it is a very important documentation because it really signifies good response to treatment and is predictive of a fairly good outcome with time. The other endpoint, which is histological remission or quiescent colitis, is absence of inflammation and persistence of chronic changes in the form of architectural distortion. And here this is defined by an RHI less than or equal to 3 or a Nancy index less than equal to 1. We know that histological inflammation has been linked with bad outcomes, such as development of neoplasia in the colon. Here, these are several cohort studies from different parts of the world. When pulled together, indicate that persistent inflammation in the colon is associated with more than 2-fold increase in the probability of developing colon cancer with time. Another outcome that has been associated with persistent inflammation microscopically is relapse. And here we can see that patients who had documented histological remission were less likely to require were less likely to develop a relapse with time compared to those who did not have histologic remission or had persistent inflammation. Now, the important thing to consider on clinical basis is that sometimes there's discordance between endoscopy and histology. So sometimes you can see that endoscopically the bowel looks perfectly healed and normal with no evidence of inflammation, yet when we take biopsies, up to a third of patients can have persistent microscopic inflammation, which brings up the importance of documenting the degree of histological activity, even if we can see that endoscopically there is no evidence of inflammation. So again, we see that the more we delve into the literature and into science, we develop more expectations with regards to outcome, and we try somehow to alter the natural course of the disease. But the question is, how can we reach these deeper forms of remission? And is it actually possible? Through reliance on literature from other specialties, such as the rheumatology literature, we adopted the strategy of treat to target in inflammatory bowel disease, which depends on multiple things. Number one, using validated, reliable outcomes, such as the one I mentioned, establishing perfectly predictive timelines, and using reliable tools to evaluate a response to treatment. And we go through the cycle of reevaluation and adjustment of therapy on and off until we reach the target that we have preset with time. And hopefully, if this strategy is followed, then those deeper forms of remission can be achieved. Now, this is the STRIDE recommendations by IOIBD, which was published back in 2017. And I'd like in this these two slides to highlight how, for example, both clinical and endoscopic parameters were identified as targets of treatment, but histology, conversely, was identified to not be a target, and this was through agreement by the majority of the participants in this group of physicians that made the recommendation. Of course, CRP and calprotectin were both used as surrogate markers of inflammation, but not as hard targets. This is a summary of the STRIDE guidelines that I just mentioned, which has directly been tied to the treat to target strategy. Of course, some of these endpoints are not without disadvantages and limitations. And one of the limitations that was initially highlighted in histology was the lack of validated indices. But since then, like I mentioned, the two new indices that have been developed have been used both in clinical trials and clinical practice after its operating characteristics have been clearly evaluated and characterized. Of course, this is the newest iteration of the ECHO position statements regarding histopathology in ulcerative colitis. And in comparison to what I just showed you in the 2017 STRIDE guidelines, here we can see how there has been a shift towards recognizing histology as an endpoint of treatment in ulcerative colitis. As you can see here, all these statements, 1.3 to 1.7, with very high degrees of agreement among participants, shows histology as an endpoint that should be used both in clinical trials and in clinical practice through documentation by biopsy. And on the left here, you can see that histological remission is a target for treatment in ulcerative colitis. There is evidence that persistent histological inflammation correlates with adverse outcomes. Of course, this is only 3 years after the prior STRIDE guidelines. Now, of course, the question that remains, is there enough therapies out there to reach both endoscopic and histological remission alone or together. Of course, there's so many classes of drugs that we use in our daily clinical practice, and almost any of them, when used properly, can hopefully, and of course, in combination with the treat to target strategy, can hopefully reach these outcomes. And I'm going to give you some examples. Of course, this is the treat to target approach that has become standard of care. Now, this is the varsity study data that compared adalimumab and vedolizumab. And the point here, not to compare both agents, but to show that how both agents were able to drive histological remission in a significant proportion of patients. And in this study, this was defined through the robust histological index of severity of less than 3, as we mentioned. Another class of medications, which is the anti-cytokines. And here I'm starting with ustekinumab, the anti-IL-12 and 23, which we'll hear more about later in this webinar. In the Unify phase 3 study, again, we have multiple outcomes related to these deeper forms of remission. On the left side, you can see how patients who received 90 milligrams of Stelara or ustekinumab every 8 weeks, 60% of this population reached histological improvement, 51% reached endoscopic improvement, and close to half, or 46%, had both histological and endoscopic healing at the same time. Another new drug that is now used, or hopefully reaching final stages of drug development, which is upadacitinib, again, was evaluated in this phase 3 study. And as you can see, in patients that received the 15 milligrams once per day of this drug, which is a JAK kinase inhibitor, developed histological improvement, which is a very significant proportion of patients in these types of studies. Again, another new drug, which is an anti-cytokine, an anti-IL-23, mirikizumab, which was studied in this phase 2 clinical trial in patients with moderately to severely active ulcerative colitis. Here you can see that the cohort that received the 200 milligrams per day of this drug reached histological remission, and 24% reached mucosal healing. Now, this is, of course, at the end of induction. And if you look at following 52 weeks of treatment, we can see that close to, or even more than 2/3 of patients developed histological remission, and more than 80% had durable histological remission with time. Again, we can see here, even with these new types of medications, histology has become a very prominent outcome used in these studies. But there is good news, and even better news, that there is a very large, important study, which is the prospective study to evaluate therapeutic targets in ulcerative colitis, or the VERDICT study, that is has been launched and is currently undergoing, which will compare 3 endpoints of treatment: treat to symptoms and endoscopy, and treat to symptoms, endoscopy, and histology through vedolizumab. Hopefully, this will shed light on the proper and most reliable way or method of evaluating patients in clinical practice for ulcerative colitis. So in summary, deeper remission is associated with favorable outcomes both in Crohn's and in ulcerative colitis. Histologic remission is an evolving outcome that has become part of treatment strategies for ulcerative colitis, both in clinical practice and clinical trials. Treatment with biologics is capable of achieving histoendoscopic remission. Treat to target is currently the standard method of treatment in ulcerative colitis. Achieving deeper levels of remission requires periodic assessment of both objective measures and patient-reported outcomes and appropriate adjustment of therapy. This is, of course, through the treat to target strategy. I'd like to end by thanking you for your attention, and I'm open to any questions at the end of the session. Thank you very much.
Oh, thank you so much, Professor Mahmoud Mosli. That was really very interesting and very informative. I really thank you for this very nice presentation. And of course, I thank you for illustrating very important points. And you really showed how we are thriving to reach deeper and deeper remission, which I think we are on the track, but we didn't still reach. Hopefully, we will going to reach this very soon. I also like this wonderful dream slide of Column Bell, which you presented. It really shows that we are really living the dream and we are going to reach it one day. So thank you for this very nice presentable slide. Maybe I'll ask you to send it to me. Thank you. And I again ask you just to wait to the end of the third talk. By that time, we are going to start our discussion. So kindly wait with us. And now it's really, again, my pleasure it's really a great pleasure to introduce my colleague and dear friend, Professor Afify Fahmy, who is a professor of internal medicine at the Azig University in Egypt. Afify is a well-known gastroenterologist and an IBD specialist. He is a great clinician and a very practical and thoughtful man. His great interest in IBD made him one of the most active members of the Egyptian IBD Society. Professor Afify will address a very important topic, which is Stelara innovation in ulcerative colitis. Professor Afify, the screen is now yours. Please unmute Afify.
Hey, Dr. Sherif?
Oh, yes, go ahead. You can start, Professor Afify.
Thank you, Professor Sherif, and it's my pleasure to be with you and with Professor Mosli for this outstanding conference. Today, Professor Mosli paved the way for me to talk about a very important topic, which is Stelara or Secukinumab for lasting remission. He told us about the importance of deep remission, meaning endoscopic and histologic remission for a better outcome and for a good response of the patient. As we see, Secukinumab or Stelara for remission in IBD, now it's approved for UC after 3 years of approval for Crohn's disease. It's indicated for the treatment of adult patients with moderately to severely active ulcerative colitis who have had inadequate response with or lost response with or were intolerant to either conventional therapy or a biologic or have medical contraindication to such therapies. Whenever we are talking about a new drug in our armamentarium, for sure we need a drug with a rapid response, with lasting remission, and demonstrated safety and convenient dosing. Now it's about more than 10 years for the use of Secukinumab or Stelara. It's first used in 2009 in plaque psoriasis, and then psoriasis arthritis, and pediatric plaque psoriasis, and then Crohn's disease, and lastly, ulcerative colitis. So Stelara has 10 years heritage in related immune-mediated inflammatory disease across 5 indications, and this length of treatment and this long journey make us have a data of rapid response, as I said, with lasting remission and demonstrated safety and convenient dosing. First of all, one of the very important items related to ustekinumab is its immunogenicity profile at 3 years. If we compare the immunogenicity of the anti-TNF infliximab and that adalimumab and ustekinumab, here we can see ustekinumab is only 4.8 in comparison to 23% and 42% of infliximab. And the important thing is that even with this very small immunogenic profile, this profile doesn't affect, or this immunogenicity doesn't affect the speed of infliximab. This means that your drug has a lasting effect, and the effect is durable, and there is no failure of treatment, mechanistic failure or something like that. That is a very important item. Also, for 10 years more than that, we have the psoriasis longitudinal assessment and the registry. Here is the registry following more than 12,000 of patients with psoriasis, some of whom had also a psoriatic arthritis or IBD. Within the overall solar population of patients with psoriasis, 2.3% also had IBD at enrollment. Here we can see the adverse events of special interest as regards ustekinumab is very low during this big period of use of the drug, which again satisfies you as regards the safety profile. To talk first about the rapid response and the durable remission of ustekinumab, I will talk today about the Unify study. Here, the Unify study, people are randomized either to placebo or to fixed dose of ustekinumab IV 130 or to weight-based drug, which is a dose which is 6 milligrams. After 8 weeks, the patient were assessed, and then at week 8, they are again randomized. Both with placebo, which show response will continue throughout the maintenance study, and the patients on the active ustekinumab, the fixed dose or the weight-based dose, if they respond, they will again enter the maintenance part of the study, and they will randomize. Some of them receive placebo, some of them receive ustekinumab 90 milligrams sub-Q every 12 weeks, and some of them receive ustekinumab 90 milligrams sub-Q every 8 weeks. Those who will not respond in either one of the randomized people, if placebo non-responders, they will receive ustekinumab 6 milligrams per kg IV, and the ustekinumab, if they don't receive, they again receive a sub-Q dose and evaluated after 16 weeks. If they still not responding, they will be out of the study. If they respond, they will enter the maintenance part of the study. Now, there are certain important definitions to be set before doing the results of this marvelous study. The global, there is clinical remission, and they use the global definition or US definition. Global definition means score of equal to or less 2, with no individual subscore more than 1. The US definition is more stringent. It defines absolute stool number of less than 3 or equal to 3, rectal bleeding subscore 0, which is a tough item, and the EMEO subscore of 0 or 1. Secondly, endpoints at week 8, there will be clinical response, which decrease from baseline in the EMEO score more than 30% or equal to or more 3 points, with either a decrease in rectal blood in stool, blood in stool more than 1, or of 1 or 0 or 1. Endoscopic healing, Mayo endoscopic score of 0 or 1. Histologic healing, 0 to less than 5 neutrophils in epithelium, no cleft destruction and no erosions. Mucosal healing combines both endoscopic and histologic healing, quality of life, change from baseline, IBDQ. Here, just to shed some light about the UC characteristics at baseline, I want here to highlight that about 50% or half of patients are difficult patients. They are biologic failure. About 50% will fail. These patients try one biology or more than, and this will be viewed in the next slide. So we have about 50% of patients with prior biologic failure. And the subjects with a history of biological failure in the study, at least one anti-TNF, regardless of VIDO, or only anti-TNF, not two, VIDO, or any anti-TNF and VIDO both. So we have a sector here who failed TNF and another sector VIDO failed VIDO only. So about 50% were patients of difficult to treat. Now, what is the results as early as 8 weeks? According to global definition, so we can see those with a biologic failure before about 12.7, and those without prior biologic failure 18.6. So we find here, to some extent, the response is good in biologic naive patients. Use the US definition is more stringent. Here also again, those at as early as 8 weeks, we find that about 1/4 or 25% of patients who are biologic naive are giving this early response, and which is a favorable response as so early. According to what my colleague Professor Mosli said, now our aim is histological healing. Secukinumab Stelara is the first and the only approved UC treatment to achieve histo-endoscopic mucosal healing, which is the ultimate outcome, which prevents further hospitalization versus needs for surgery and the good quality of life. Endoscopic healing by biologic profile. Again, endoscopic healing after 8 weeks is about 33.3 in biologic naive in comparison to biologic failure. Also, it shows how the secukinumab is better used before biologic failure, and it gave a good result in biologic naive. What about histologic healing? Again, as early as week 8, here about 35.9% of patients use this favorable response. And here I stress about why histologic improvement, because it is linked with improved clinical outcome, such as a reduced risk of relapse and the need for surgery, hospitalization, and the reduced risk of developing cancer. So this is the future. We will be, all of us, aiming at deep remission, means endoscopic and histologic healing. Again, the deep remission or histo-endoscopic healing, again, after 8 weeks, there will be about 18.4 in the dose, which dose according to the weight of the patient or weight-based dose. The clinical response, again, by biologic failure, after 8 weeks, clinical response 66%. 0.7% in biologic naive in comparison to biologic failure before or experience of biologic before, which is 57.2. Response by biologic failure at week 8 and 16. Some patients who failed to achieve clinical remission at week 8. They were also supposed to have one sub-Q at week 16. So at week 16, the number of patients increasing 67% to 87%, which is a very good number and a very good result to achieve this clinical response after 16 weeks. Again, something measurable, which is the fecal calprotectin concentration milligram per kg. Here we can see at week 6 and week 8, the reduction in the weight-based dose of ustekinumab is very significant. Now, the other, almost whenever we are talking about the power of the drug or the effectiveness, we must not forget to demonstrate what about safety, the other side of the story. Key safety findings through 8 weeks. Here, no malignancies recorded. Even the serious adverse events nearly equal to placebo, infections and adverse events in general. Here we can find that we are talking about a drug with a safety of a high safety profile, nearly like placebo. In general, a single intravenously administered dose of 130 or weight-based 6 mg per kg ustekinumab was well tolerated through 8 weeks. No dose-related safety events were observed. Rates of adverse events similar across treatment groups. Serious adverse events were not commonly reported. There was one death, but it's not attributed to either the disease or to the drug. It is due to esophageal varices rupture and the hemorrhage reported in the arm of weight-based drug. Rates of infection similar across groups. Serious infections were infrequent. There were no cases of TB or opportunistic infections. So the adverse events are also adverse events occurring within hour of an infusion. These were similar across treatment group. So a high and very nice safety profile. Now, what about the maintenance data? Again, the maintenance data from week 0, it's not 0 here, after 8 weeks to week 44, which is 52, week 52. Then what about the durability? What about the effect of the drug, which will be throughout the maintenance period, according to week 44, which, as I said, it's 52. If we add the 8 weeks before, what we will see? Clinical remission at week 44, again, it is very significantly 42.6 in the US definition of clinical response and 43.8 in the global definition. And there's a difference between every 12 weeks versus 8 weeks. There is no statistical significant difference between both groups. Here about clinical remission by previous biological failure status. Here we find that in bio-naive shows the highest rate of remission in comparison to biofailure, in comparison to failure of more than one anti-TNF or failure of one anti-TNF individual. Here, the significance of using ustekinumab Stelara in bio-naive, if indicated, is very important because the results in bio-naive is more than that in bio-failure. What about the overall population at week 44? The overall population, those with response at 8 weeks and those with response after 8 weeks at 16 weeks, the overall population 71 here at week 44, or by the end of the year, we have 71 with clinical response. About endoscopic healing, here again, there is a very significantly good response, 51.1. And again, the difference between both those with the 8 weeks or 12 weeks is not to some extent significant. Histologic healing, again, there is a good percentage of patients with histologic healing. Again, deep remission means endoscopic and histologic healing, histoendoscopic healing, again, 45.8, 4.9 and 38 in the every 12 week, and that for every 8 week. Steroid-free remission, which is a goal before you can withdraw steroids freely and the patient maintain. Again, the results are very nice. 40.9 and 42 patients with, according to the US and the global definition of clinical response. The same as regard the fecal calprotectin, the fecal calprotectin decrease. Again, it shows a very good and a sustainability of biochemical response. That's very nice. What the median IBD-Q score, it also shows the sustained quality of life benefits through maintenance period for both ustekinumab doses. So, according summary of the efficacy till week 44, subjects with moderate to severe UC who responded to a single IV induction and either received ustekinumab every 8 weeks or 12 weeks, they achieved clinical remission, they maintained clinical response, they achieved corticosteroid-free remission, they maintained the clinical remission through 44 among those subjects who were in remission. And maintenance treatment with ustekinumab also resulted in sustained improvements in quality of life, sustained partial Mayo remission, and sustained reduction in biomarkers, including CRP and fecal calpro markers. Now, what about those who shows delayed response? The key maintenance data, summary outcome of delayed responders at week 16, they show a good clinical response, and even with histological improvement. So delayed responders show well, and if your patient doesn't give you the favorable response after the first induction dose, please give him the second sub-Q dose, and a good percentage of patients will show response at week 16. The summary of outcome in delayed responders at week 44, they show a good clinical response and even histoendoscopic healing. Our drug Stelara as a monotherapy in IBD, you don't need to combine Stelara or ustekinumab with any immune modulator, because up to week 92, those with and those without immunomodulator, the results nearly the same. So as we all know, and most of the anti-TNF and some other drugs which work different by different mechanisms need to be combined with immune modulator and show good response with the addition of an immune modulator. For sure, addition of immune modulator will decrease the immunogenicity, but on what price? This will increase the side effects as regard malignancy or serious infections. So if you have a drug which works as a monotherapy and it doesn't need to be combined with immunomodulator, that's good and interesting. And also immunomodulator use didn't affect serum Stelara concentrations. This is because I show in the first slides about it. It's a drug with a very low immunogenicity profile. Now, what about long-term extension? As you see, through week 92, about 83.2% of patients still showing good remission and good condition. In the safety, so at week 44, there is no significant difference between it and the placebo as regards serious events or serious infections or malignancy. It's not statistically significant and placebo. So the safety profile is very important in this regard. I will not repeat. Even the malignancies which were reported were very, very, very small number. So for summary of the safety at 1 year, less than 1% hypersensitivity reaction, less than 1% malignancy rate, less than 2% serious infections, and less than 5% of patients develop antibodies. That is because it's immunogenicity of the drug, of the drug, is very low or very minimal. This is the last two slides. So long we don't have a head-to-head trial differentiating or comparing the different molecules, either anti-integrins, anti-interleukin 12-23 with the anti-TNF or small molecules. We don't have these comparative studies, but if we pull some data, if we pull the data from the internet, we can have this nice slide, which shows to you that clinical response at 1 year pooled treatment arms, we have about 70.7% as regards ustekinumab or Stelara, and no one can reach this figure, either the tofacitinib, adalimumab, Vido, or something like that. I stress that these are not head-to-head studies, but these are pooled data to show you some information about the durability and the effectiveness of ustekinumab. And this is the on left-hand side. This is in biologic naive, and here, and the same story in biologic failure. What about convenient dosing? Here, single IV induction. During a year, you need only four injections, so the convenient dosing is very important. As regards Stelara, it's the sum of 5 injections, Vido 8 injections, and Adalimumab 27 injections. So to conclude, we have 10 years heritage efficacy from a single IV dose with a high percentage of responders, lasting efficacy with a minimal corticosteroid use, and a consistent safety profile with a convenient dosing. Thank you.
Thank you so much, Professor Afify. You clearly illustrated the wide safety range of this drug and the effectiveness of the drug both in Crohn's disease and ulcerative colitis. So thank you for this very illustrating and a very clear lecture. And there will be a change in the agenda because maybe Professor Mosli has to leave us, unfortunately, although he's, of course, enjoying the discussion with him. But there will be a couple of questions, and then we will continue with Professor Tamer. But for the time being, we will just discuss with Professor Mosli and maybe a few questions with Professor Afify. Then we will continue with Tamer. So first of all, Professor Mosli, of course, before you start treatment of your patients, definitely you assess the severity of the disease and you assess the inflammatory burden, and also you need some domains to assess the prognosis of the disease. So can you just throw some light about these domains you use, both in assessing the severity and in assessing the prognosis of your patients?
Yes, thank you for that very important clinical question. So it really depends on whether or not I'm talking about a patient at baseline. So this is the first time I'm coming to know this patient and how his or her disease behaves. But in general, at baseline, all patients obviously get laboratory testing, of course, after clinical assessment, laboratory testing through biochemical markers both CRP and fecal calprotectin, in addition to a general panel of tests. So to, for example, evaluate severity, I need to know if there is any anemia, know more about their nutritional status, so looking at their albumin. And obviously, if I'd like to start them on medication, I'd like to have a baseline creatinine, liver enzymes as well. So that's something I do routinely. Of course, moving next to the endoscopy, a full ileocolonoscopy is always expected at baseline to document disease extent and disease severity through documentation of the Mayo endoscopic subscore. Of course, if the disease, for example, is pancolitis, it differs compared to whether or not the patient has, for example, proctitis or left-sided colitis, because treatment in both conditions differ, of course. Now, let's say somebody is known to have ulcerative colitis or has an established diagnosis and has been doing well, but later on presents with symptoms of a relapse. Assessment might differ a little bit. So at this point, a flexible sigmoidoscopy, for example, might be sufficient to document severity of the disease. And of course, fecal calprotectin, in addition to sometimes some tests to rule out causes of a flare, such as stool culture, stool for C. diff, which is not as uncommon as we think it is. Now, with regards to prognosis, I don't have any prognostic parameters that I rely on in my daily clinical practice, other than what I have mentioned. But in general, other things such as requirement of steroids, requirement of hospitalization, and presence of complications at the time of the initial presentations, I consider these to be the most important predictive prognostic markers. Another one that is highly cited in the literature is the presence of deep ulcerations, and of course, persistent severe inflammation with a Mayo subscore of 3, despite treatment using a biological agent. So these are really the ones I use in my daily clinical practice, Professor Sherif.
Yes, that's great. Thank you so much. And what about P-ANCA and ASCA? Not in diagnosis, but they are talking about them as prognostic factors in ulcerative colitis. What do you think?
So the only indication where I use or rely on ASCA and ANCA is usually if a patient is going for colectomy and for a pouch. That is usually when I send patient for ASCA and ANCA because that's where I find that the test is mostly accurately predictive. And there was a study published a few years back that documented that this is the most reliable way, although not perfect, to predict whether or not the patient would develop Crohn's disease with time, because that's usually a concern when you're constructing a pouch. But in clinical practice, I don't usually rely on it because it's neither sensitive nor sensitive.
Thank you so much. Professor Afify, do you have any addition to this comment?
No, I want to ask the question for you, Professor Sherif, or for Professor Mahmoud. Sometimes there is a discrepancy between the clinical situation and the biochemical markers. You find the patient is nearly without symptoms, no bleeding, no diarrhea, no abdominal pain, but the fecal calpro after 3 months of induction of therapy is still high. At that time, after 3 months of induction of therapy, you will do another endoscopy, or you will rely on the biochemical, and is there a lag or delay for the biomarkers to return to normal? I need to hear your opinion and the Professor Mosli.
Sure. That's a very important point, and really there is usually a discordance between clinical findings, the patient-reported outcomes, endoscopic findings, and even pathological findings. This discordance is the main reason why we are looking forward to other biomarkers, which will be maybe more accurate in making things more and more definitive. because this discordance really is in our daily practice. We can observe it. Really, we know that endoscopic healing carries a very high percent of remission or a long-lasting remission. Pathological also remission means that the patient could keep for a long time in this remission. But however, this is not the rule in many cases. And the real explanation for this discrepancy, really nobody knows. And the literature has been talking about this in many, many, many papers, and the discrepancy still exists. And the hope is that we will have more definitive biomarkers or more tools which may be collected together to give us a definitive measurement of the remission of the patient. What do you think, Professor Mosli?
Oh, no, I completely agree. And if we go back to the treat to target strategy and the STRIDE guidelines, what we usually do is repeating at least a flexible sigmoidoscopy 3 months post-induction to document endoscopic response and hopefully remission. And if for example, you do a fecal calprotectin at that point, and of course the patient developed or demonstrated clinical remission, and then there's biochemical remission, you might be able to delay that endoscopy, let's say 3 months or so. But if there's a discordance and you're concerned about whether or not there is persistent inflammation, then maybe that's when you should go ahead and do endoscopy. Bearing in mind that even in patients who are in clinical remission, not in this scenario, but in general, if you document an elevated fecal calprotectin and the patient is in remission, you should keep in mind that this might be predictive of a relapse that is coming with time, because that is one of the utilities of this test, is being predictive of relapse.
Great, thank you so much.
Professor Sherif, may I ask a question?
Sure, definitely. Go ahead.
Yeah. As shown in the Unify study, that the results of stikinumab in biologically naive is better than in post-biological failure before. Do you expect in the near future the guidelines will change for using stikinumab not after failure of anti-TNF and to be used as a first-line therapy?
Well, definitely, yes. This is a very good observation, and of course, findings and patients' experience, a number of patients which are increasingly taking stikinumab, the results of therapy is showing the good results and the safety. And even if patients would start stikinumab and fail, you can start another TNF or anything, because this is a very, very low immunogenic drug. So it's very safe to start the drug as a primary drug in naive patients who did not receive any biologics before. But yet, up to this stage, we have to use it as guidelines tell us. But in the near future, we have found that there is, of course, some changes in the guidelines relying upon the experience with patients with good results and the safety profile and the ability of using such a drug and then turning on to another drug without any failure of response to the medication, especially if you have stikinumab or other new biologicals, even they have also this advantage. So for sure, I thank you for this good observation. But I've got a question for you, Professor Afify, coming from audiences. In a middle-aged female with psoriasis, what will be the choice of treatment in such a patient if you're going to give her a biologic?
Yes, if she has psoriasis and ulcerative colitis, for sure. If she can offer stikinumab, it will be a nice choice.
Very. And what about vaccination in your patients? And I mean COVID vaccination, not the...
according to the general rules, if it is killed vaccine, you can give without any fear. But if it is live attenuated vaccine, it's contraindicated with use of biologics.
So if you are talking about, for example, messenger RNA vaccines, do you think these are going to be safe to vaccinate our patients who are on biologics, in your opinion?
Messenger RNA vaccine, it's not a live vaccine.
It's a recombinant.
Yes, so they can use it.
What do you think, Professor Mahmoud?
I think so far all the reports have supported that it's safe. And I think that we'll learn more with time. So maybe in the next 3 months it'll be more clear. But the initial reports that it's safe and it's actually recommended for patients who have chronic illnesses and such. So I have been generally advising my patients to seek vaccination.
Very good. That's a very important question because our patients already started to ask if the vaccine is available. Am I going to get the vaccine or not? So of course it's safe, the messenger RNA, but we don't have a lot of data, a lot of reviews, and we have to wait and stay. But the message is we have to be also cautious. So I think that would be the message.
Professor Sherif, I want to add something here because some of my patients by themselves reduce the dose of the biology of their biological drug, and they reduce the dose of immunomodulators by their own, not on my request, because they are afraid of COVID-19. So I hear stress to the audience and to my colleagues to reassure their patients if they are free, if they are not having COVID, or if they are not in close contact with a COVID patient, not to reduce their drugs, because to have their illness under control is very important.
Thank you. Thank you. Very good for this message. And thank you, Professor Mahmoud. Thank you, Professor Afify, for this discussion. It really was very fruitful. And of course, we wish that Professor Mahmoud would continue with us, but I know that he is obliged to leave us. So we are looking forward to see you in further meetings. And we thank you for the talk. Thank you for the discussion, and see you later. Now,
thank you very much.
Thank you. Now it's my great pleasure to introduce Professor Tamer Elbaz, who is a professor of endemic hepatology and gastroenterology at Cairo University. Besides his interest in management of various hepatic disorders, and specifically his experience in HCC, he is a very skillful clinician and one of our outstanding video capsule endoscopy commentators. His interest in video capsule endoscopy started many years ago. And besides a bunch of publications, I'd like to invite you to read his publication on the role of video capsule endoscopy in obscure gastrointestinal bleeding, which was published in the Arab Journal of Gastroenterology. Professor Tamer will take us through an interesting journey. I know that it will be very interesting, and I promise you that you will enjoy it. On the title, Hands-on Training, Small Bowel Capsule Endoscopy, Professor Tamer will start his journey. Professor Tamer, the screen is yours.
Bismillahirrahmanirrahim. Professor Sherif Mogawer, many thanks for your kind words. It's an honor to be with you in any session, and many thanks for Hoya Training Center for that session. Today I'm going to present capsule endoscopy. I had been experienced it since 2006, and I would like to share, let's say, from A to Z in capsule endoscopy in a limited time, I know, in 30 minutes. So my agenda today, I will proceed first with introduction to capsule endoscopy and its systems and the different capsule endoscopy systems that are present worldwide. Then how to professionally read a capsule endoscopy. And specifically, I will present some few slides about capsule endoscopy and Crohn's disease, as long as we are talking about inflammatory bowel disease today. Then some case presentations for the different indications of capsule endoscopy. First of all, we will start with capsule endoscopy, the picture for the first capsule endoscopy that was presented in 2000, and they named it M2A, and that means at the time mouth to anus, for the first time to visualize the whole small bowel and the whole GI tract using a simple non-invasive technique. And actually nowadays we have 5 video capsule endoscopy systems worldwide. It first started with a given diagnostic system, the PillCam capsule endoscope generated in USA, that was in 2000. That was followed by the Olympus capsule endoscopy system in Japan, the EndoCapsule. Then it was followed by the MiroCam and at the same time, smart capsule. The first one from Korea and second one from China. And finally, with the Capsule Cam that was released by a different system in USA. Usually, the diagrammatic scheme for any capsule, usually the most important part that it can capture photos and there are certain light sources. Then there is a sensor to gather the information that can be sent using a transmitter to a data recorder, and the batteries that will allow the capsule endoscopy journey for 8 to 12 hours. Picture for the 4 different systems that are using the same principle, the pill cam, the mirror cam, the Olympus, and the we can see that there is a dome, transparent dome with the presence of the camera at the top, and the angle of view is around 150 to 170. And the different system applied by the capsule system, you will see that the camera is side viewing and it's taking a picture through the 360 degrees. Other versions from the capsule endoscopy happened since its introduction. So we found, for example, in the pill cam capsule, there are the small bowel first and second, and the third edition, there is the esophageal pill cam capsule, and there is a colon pill cam capsule. And then in the mirror cam, we can see the one capsule with 2 views. That's a picture for the mirror cam. And then even you can notice that even for a single company like the mirror cam, they are producing capsules with single or double view and with different times of visualization. They produced an echo-free system with a mercury-free battery, and they developed another capsule endoscopy that can control the movement of capsule using a magnetic controller, but it's not available up till now in Egypt. That's the size of the capsule endoscopy. It's small. It's around 30 millimeter by 11. And that's the usual system that we have the capsule, and we have the leads that are attached to the abdomen, like the ECG leads, and they are connected by a cable to a data recorder. And this data recorder will be connected to a certain software that's present for visualization of the films. And even for the data recorder, we have different versions. We can see this one and this different one for the same for the same principle. Here you can visualize the capsule endoscopy live while it's proceeding. For certain points, I will mention later on that it will be important to know where is the site of the capsule endoscopy. For the systems, as I said, the dimensions are almost the same and the weight is almost the same, but the field of view is around 156, 140, and up to 170. The frames per second, that means how many pictures are taken per second. We are talking about an average from 2 to 6 frames per second. And the battery life is around 10 to 15 hours. That's the picture for the usual software. You can notice, you can see it as a single view or double view. You are controlling it from this panel. You can either take it forward or backward, and you can determine the speed of visualization of the films. You can take pictures, and as you can see down, they are taking the pictures, and you can write your annotations. You are taking landmarks. It's important while visualizing capsule endoscopy to put a landmark at the start of the stomach, and then another one at the start of the duodenum. So you are denoting the gastric transit time, and you are taking another landmark at the entry at the cecum. So you are mentioning the small bowel transit time from the first duodenal image to the first cecal image. Different systems, the Olympus one, there are the same principles you can notice, and there are certain modifications between one system and the other. That's the Capsule Cam system. You can notice that in the previous systems, you are visualizing the capsule endoscopy like your picture in endoscope. For those who are working in endoscopically, upper, lower, or whatever, you are visualizing the small bowel like the same one. But in Capsule Cam, it's different. It's taking a panoramic view of 360 degrees. Sometimes it's beneficial to visualize the whole bowel at the same time, but it needs more experience than proceeding with the other capsule endoscopy systems. Some modifications that are important while visualizing the capsule endoscopy, we have something called the suspected blood indicator. In patients with obscure GI bleeding, if you have a visualization of 12 hours and you need a rapid decision while starting visualization of the capsule endoscopy, you can use a suspected blood indicator, so the system is collecting just the pictures with a red sign, denoting either a vascular lesion or active bleeding. In the mirror cam system, for example, you can notice, as I showed you before, that you can use the one with the camera on one side or both sides. If you are using the edition with two cameras, you can see both from the right and from the left. And so you will notice that the pictures here are different. I am going back again. You will see that the picture is the same here, but in that one, right and left, using two cameras, you are seeing the abdomen and the lower dome at the same time. So it's a benefit to use this one. You are visualizing the 360 degrees by another way. You can see this, what we call it, the tracker for the capsule endoscopy. In some cases, the capsule endoscopy doesn't reach the cecum, and you would like to know where are you exactly when it finished the capsule endoscopy. Maybe it's still in the jejunum, facing, for example, a mass that prevented the further passage of the capsule, or you are at the ileum. So using this one, this box, you can notice that there is a yellow point. If it's present in the left upper quadrant, usually it's the site of the jejunum, and if it's present at the right lower quadrant, you are at the ileum and approximating to reach to the cecum. So it can help to know where is the capsule endoscopy in the abdomen at that time. Indications of capsule endoscopy, of course, the main indication while using capsule endoscopy is the obscure GI bleeding that could be overt. The patient is complaining of active bleeding, of actual bleeding, or it's an occult with patients with iron deficiency anemia, or fecal occult blood test positivity. In patients with Crohn's disease, the suspected, and in the follow-up of some cases, suspected small intestinal tumors and surveillance in patients with polyposis syndromes, suspected or refractory malabsorptive syndromes like the celiac, it's important, and the evaluation of side effects of non-steroidals. Non-steroids are known to, as they are producing gastric ulcerations, duodenal ulcerations, but they are known also with duodenopathy, jejunopathy, and ileopathy. And sometimes we can notice ulcers that are mimicking the inflammatory bowel disease ulcers, and even sometimes they can be more aggressive, and they are called diaphragmatic ulcers due to their ulcers taking the whole circumference of the small bowel. Other less common indications that unexplained chronic abdominal pain, and while working, some patients with chronic abdominal pain were diagnosed with lymphoma. Actually, diffuse intestinal disorders like Whipple disease, esophageal diseases for the esophageal capsule, and the screening for colorectal cancer, the colon capsule, but it's not that common, and it needs a different discussion because there are some recommendations specific for the screening of colorectal cancers. Limitations of capsule endoscopy, also the main benefit that it's non-invasive and it can visualize the whole small bowel, but still it lacks the therapeutic capabilities. I cannot manage bleeding I visualize during examination, inability to control its movements for the GI tract, difficulty in localizing the lesion. As I said, it's upper lower quadrant, but you cannot define exactly where are you. For example, I cannot say that the lesion I'm seeing like a mass is 50 centimeters from the pylorus, for example. No, it's not that point. You can mention that it's early, mid, or late jejunum, early, mid, or late ileum. Lack of specificity. Some lesions, that 40% of incidental findings in healthy volunteers, starting with capsule endoscopy, healthy volunteers, while performing capsule endoscopy, they had normal hemoglobin, they never bled, and still we found, for example, angiodysplastic lesions. So it's a lack of specificity. Failure to identify the major papilla, it's a major problem for staff working with capsule endoscopy. So it's not indicated as a capsule endoscopy to visualize lesions that are present in the duodenum. Usually that's the job of the upper endoscopy. Safety, patients with known or suspected GI obstructions, strictures, or fistulas, of course, they are not allowed to perform capsule endoscopy. Patients with cardiac pacemakers or other implanted electromedical devices, of course, because it can interfere, the waves of the capsule endoscopy can interfere with the cardiac pacemakers. patients with swallowing disorders, but there are some introducers that can be used in such conditions, and of course with pregnancy. Second point, how to professionally read a capsule endoscopy. There are 10 important rules or lessons you have to know while proceeding your experience with capsule endoscopy. First one, in capsule endoscopy, source of GI bleeding can be simply presented in 1 or 2 photos. For example, the angiodysplasias, while the capsule endoscopy is moving, it can take a picture for a capsule endoscopy for 1 or 2 seconds only, and then it's moving thereafter with peristalsis further away from the lesion, and you cannot regain the capsule endoscopy to visualize the lesion again. So take care, maximum focus to avoid missing lesions while you are seeing the 8 or 11 or 12 hours of examination. In the opposite, chronic diarrhea is usually presented by diffuse pathology. For example, patients with inflammatory bowel disease or celiac, that's a diffuse pathology, and you can visualize the almost maybe the whole bowel affected. Second lesson, that's important, try to follow your patient till you make sure the capsule passes to the duodenum. And that's the importance of the data viewer I told you about. Like in different systems, there is a real live viewer while doing the examination. That's important. In some patients, some of them may have gastroparesis, and so the aim of the capsule endoscopy is visualization of the small bowel, not the stomach. You are not going to lose a major time of your examination in seeing the stomach, of course. So if you noticed by the data viewer that the capsule endoscopy is still in the stomach after 1 hour, you are going to give the patient a prokinetic and to follow that the patient proceeded to the duodenum, and thereafter it's taking its way. Third lesson, history taking and physical findings can guide you to the possible capsule endoscopy finding. A patient, for example, who performed APC argon coagulation for duodenal angiodysplasia, and then he is bleeding again, you are looking for other angiodysplasias as scattered in the small bowel. So history taking and physical examination is very important. Lesson 4, what about a negative capsule endoscopy in case of obscure GI bleeding? Sometimes it's frustrating that a patient is doing a capsule endoscopy and then you are facing, after end of examination, you are telling him that you find no source of bleeding. So I brought this study for negative capsule endoscopy in patients with obscure GI bleeding, its reliability and recurrence of bleeding on long-term follow-up, and they recruited 96 patients of capsule endoscopy, and the conclusion, patients with obscure GI bleeding and a negative capsule endoscopy had a significantly lower rebleeding rate, and further invasive investigations can be deferred. So patients with negative capsule endoscopy are usually patients with occult GI bleeding. They can be managed medically, and they do not need any interference thereafter. Importantly, the small bowel preparation for capsule endoscopy. The best up till now is using the polyethylene glycol solution. The best to clean. What about prokinetics? For example, the capsule endoscopy is going to stay for 8 hours. And you know that the patient has a problem, he's diabetic, uncontrolled, and you are expecting gastroparesis or slow intestinal motility. What about giving a prokinetic to hasten the intestinal motility? It's beneficial that you can visualize the whole small bowel, but its drawback that the movement of the capsule endoscopy sometimes is so fast that it can miss lesions. So do not rush for using prokinetics. Sometimes you are using simicicon. You can see in the pictures, different pictures of bad bowel preparation and the problem of bubbles sometimes that we are facing, and sometimes simicicon can be helpful in such situation. Sixth lesson, capsule endoscopy revealing no lesions, but blood, it's not a negative finding. Sometimes we are proceeding with capsule endoscopy and all what we are seeing is just blood. In the opposite, it's a strong positive finding that can guide you to the best next step and to determine your best approach. For example, if the bleeding, I noticed a lot of blood coming, for example, 2 minutes after passage of the capsule through the duodenum. So of course, I am requesting just a push enteroscope and you can visualize the lesion. In the opposite, if you can find that the blood, the active bleeding is starting as terminal ileum, you can ask for colonoscopy with terminal ileal intubation or to proceed with double balloon enteroscopy, but from anal approach. Seventh, lesson, capsule endoscopy findings. Your eyes has to be habituated for the different type of lesions. This is a picture for the normal villus pattern. It differs from one system to another. Sometimes it's very obvious like this one. This picture for angiodysplastic lesion. This is a typically fiery red angiodysplastic lesions that you can notice, but sometimes it could be just the small point you are seeing, and we call it the telangiectatic spots. Different examples for just other angiodysplastic lesions. As I said, you have to visualize the capsule endoscopy with maximum focus because such small lesions, you can miss it. That picture for different pictures for different erosions that can be flat like this one, or sometimes they are raised erosions. Alterations that could be, for example, due to inflammatory bowel disease or due to NSAIDs. These are deep ulcerations. This is a mess. You can notice the absence of the villi. There are the normal villus pattern, and this bulge with absence of villi and ulcer on top. That was a gastric tumor. This one protruding in the lumen with shining blue. That's ectopic versus present in the small bowel. Sometimes they can take the shining white appearance, like this one. These spots are lymphangiectasia. That's a cholesterol deposition in the villi, and it can take a form like a mass or a patch. That is ensilasmus. Again, different cholesterol depositions and different forms. That small polyps, small lipomas. That was ulcerations due to lymphoma, like a network of ulcerations. Absence of villi, you can notice this one, subtotal villus atrophy, that in the patient with celiac disease. And this one, that was a large hemangioma that was actively bleeding. So your eyes have to get habituation to these findings, and every capsule endoscopy system, it has its atlas. So sometimes if you are looking for a lesion for the first time, you can open the atlas and you can compare your image according, they are doing some classifications. If you are looking for a flat lesion or a protruding or an excavating, and you can find similar pictures to your lesions. The eighth one, take care of false positive findings. That's very important, and many mistakes happen for early experienced stuff in capsule endoscopy. For example, this one, it's just a simple erosion, but due to the proximity of the lesion to the dome of the capsule endoscopy, it looks like a large lesion. While visualizing the capsule endoscopy and moving away, you can notice its actual size. This one, that was in the start of my experience, and I diagnosed that patient at that time as familial adenomatous polyposis due to presence of innumerable polyps that are present in the whole small bowel. And surprisingly, when we did upper endoscopy, they all flattened with air insufflation, and they were just mammillations and not polyps. This one again, it's the volcano-like lesion. Just it's a simple raised erosion with a blood spot on top. Again, this one, it looks like a Barrett esophagus in the esophagus, a lesion, but during peristalsis, this disappears and it was just an irregularity. So these are examples for some pitfalls that can happen while visualizing capsule endoscopy. And false impression can happen from insufficient experience as well as the first time observation of the lesion. Brain cannot define lesions not previously studied. Perfect atlas endoscopies, as I mentioned, are available as well as consultations of experts in the same field. The ninth lesson, capsule endoscopy is essentially designed to examine the small bowel, but take care if you have a colonic record, you have to visualize them. For example, this were angiodysplastic lesions that are present in the colon, and they were the lone lesions that are present in the patient. So sometimes if you have a colonic record, you have to visualize it. These pictures were for polyps in the colon and proved to be adenomatous. The last lesson, what we see in front of us, these are erosions that are present in the stomach and the duodenum. If someone would believe that this patient performed an upper endoscopy before coming to us, and he was reported to have just a gastritis, while the source of bleeding was due to numerous erosions that are present in the stomach and the duodenum. Like this one, while the small bowel is totally clean and totally clear. So when in doubt for the clinic, for the quality of the previous endoscopies, ask them to be repeated if possible before proceeding for capsule endoscopy. So my third part is about capsule endoscopy and Crohn's disease. Importantly, there are nomenclature and some terms that are specific for Crohn's disease in small bowel capsule endoscopy, and they are important while reporting lesions. There are seven terms. The first one, the ascoid erosions, the small ascoid erosions like this one, small erosions that are present, the very superficial. The deep ulcerations that could happen due to Crohn's disease. The superficial ulcerations like this one. You can notice the superficial ulcerations, and it's easy to differentiate between superficial and deep while performing the capsule endoscopy. Presence of stenosis, of course, that's a problem while performing capsule endoscopy. That's why we are usually requesting for known Crohn's disease patients to perform an MR or CT enterography before proceeding to capsule endoscopy. Presence of edema, you can notice the edematous villi, especially in this picture. Presence of denudations, that's superficial, like the superficial erosions, but just taking the tip of the villi, this one. The presence of hyperemia with some lesions. So role of capsule endoscopy, of course, is in Crohn's disease is for making diagnosis. And this study published in 2017 for a meta-analysis of capsule endoscopy in small bowel Crohn's disease, it showed the superiority of capsule endoscopy for on small bowel follow-through and with enterocolitis and CT enterography, while with MR enterography, they were almost equal in suspected Crohn's diseases. And for known Crohn's disease, it showed superiority in all terms. Scoring systems, there are certain scoring systems that are specific for capsule endoscopy in Crohn's disease. We can use them, like the Lewis score that depends on the villus appearance, the presence of ulcerations, either the number or the extent and the descriptions, and the presence of certain parameters like the stenosis. Another system, simplified one, capsule endoscopy Crohn's disease activity index. It depends on presence of inflammation, extent, and structures. And we are calculating according to the lesions by a certain equation like this one. Again, for capsule endoscopy in Crohn's disease, correlation with clinical symptoms and biomarkers of inflammation. So you can check for the mucosal healing while you are treating the patient. You can predict the disease outcome. You can see the impact of clinical decisions and the assessment of post-operative recurrence. Importantly, capsule endoscopy can help in reclassification of undetermined inflammatory bowel disease. There are patients with ulcerative colitis, Crohn's disease, and undetermined inflammatory bowel disease. Applying the Lewis score I showed you before, and using the cutoff level of 135, they found that the patients with undetermined inflammatory bowel disease and they had the score, Lewis score of more than 135, while doing capsule endoscopy, all of them were later diagnosed as Crohn's disease. While patients with insignificant inflammatory activity and the count was less than 135, some of them were ulcerative colitis, one of them was Crohn's disease, and the rest remained undiagnosed as indeterminate. But what about disadvantage of capsule endoscopy and problems? Capsule retention, of course, as I mentioned, it can happen. So before proceeding, we usually proceed with MR enterography or CT enterography to assess for the patency of the lumen. Of course, we cannot take biopsies. And of course, we are assessing the mucosa only. MR and CT enterography is complementary for assessment of all layers and the peri-lesions. Some case presentations, I brought 8 cases to visualize together. First one for a male patient, 27 years old. He suffered from persistent and progressive anemia, and he had a chronic diarrhea for the last 5 months and weight loss. So his problem is anemia, chronic diarrhea, and weight loss. His hemoglobin was 8.9. It was microcytic. He performed an upper endoscopy that shows reflux esophagitis, gastritis, and duodenitis, and a normal colonoscopy. He performed a barium meal follow-through that was negative, barium enema that was normal, and CT abdomen contrast that was totally normal. So he proceeded with capsule endoscopy, and that was a picture. This one, it looks like for me, at the start of my experience, that patient was in 2007, as I remember. This patient was diagnosed first when we visualized with the data recorder. Immediately while proceeding with the patient to make sure if it passed the duodenum or not, we thought that this picture was in the stomach. While actually, so we introduced, after 1 hour, we introduced one that was more than 2 hours even. we tried with prokinetics, and the same picture was in front of us. So we introduced an upper endoscope. This is a picture. The endoscope is seeing the capsule, and the capsule is seeing the endoscope at the same time. And surprisingly, this part that was in the duodenum. The patient suffered from celiac disease with total villus atrophy, and the duodenal mucosa looks very similar to the gastric mucosa due to total absence of villi. Again, that's a normal villus pattern. We have to visualize it. And for this patient, you can notice the total absence of the villi. So the capsule endoscopy helps so much to spot diagnose presence of celiac disease. In another case of a male patient, 42 years old, with chronic abdominal pain for 2 years, he performed an upper endoscopy twice that was normal, and colonoscopy up to the terminal ileum that was normal. And he performed a CT abdomen that showed thickened terminal ileum, so he was requested to perform a capsule endoscopy. We started, you can notice the timing of the capsule endoscopy that was 39 minutes after capsule introduction, and we started to visualize that what we call it apsoid alterations. As ulcers are present. Going deeper, that is at 2 hours and 59 minutes, you can notice the presence of superficial ulcers. Going even deeper, the ulcers are deeper, and still they are single at 3 hours and 34 minutes. They are single in the field, but later on, they are taking the corners. You can notice a small ulcer, another one, and getting deeper, 30 minutes more. Ulcerations were present everywhere, and it ended with the presence of a stenosis due to marked edema at that site in the ileum. And the patient was diagnosed later on as a Crohn's disease. You can notice the edematous villi that are present here, and the stenosis, the tight stenosis that was present here. Another patient, 74 years old, with obscure overt bleeding, persistent anemia for 10 days. Hemoglobin was 7.9 gram per dl. He performed an upper endoscopy and a colonoscopy with no apparent source of bleeding. And we found, you can notice that the patient here at 11 minutes, he is in the stomach. 20 minutes, it entered the duodenum with appearance of blood. Just a few seconds later, there is a profuse bleeding that was present here, and you can notice. And this patient, later on, we found just the melena that was present, and the single lesion was present just in the duodenum, and the patient performed an upper endoscopy later on, and it was diagnosed as angiodysplastic lesion that was not clear due to presence of excess blood. But we guided the procedure, the next procedure, just to perform an upper endoscopy with deeper intubation. Another patient, a female patient, 50 years old, obscure overt bleeding with ongoing melena. Her hemoglobin dropped to 4.4 gram per deciliter, and she took repeated blood transfusions. She did an upper endoscopy that was free. Colonoscopy showed a single AV malformation that is clipped, and the patient was non-systemic lupus and the history of stroke before, so patient was on steroids and an anticoagulant. Just 4 minutes after passage through the pylorus, active profuse fresh bleeding was noticed. After that fresh bleeding, a dark altered blood was seen. Again, a second side of fresh bleeding is seen in the mid-jejunum. Another third and another fourth fresh bleeding was seen at the late jejunal in the early ileal regions with profuse blood. Then dark altered blood and the melena are seen till end of visualization at the cecal region. You can see here the fresh blood, then dark altered, another fresh blood, this one, then dark altered, another fresh blood, and a fourth fresh blood. That's important. That means that we are not dealing with a single lesion. You have to ask for a double balloon enteroscopy or an angiography to manage multiple lesions that almost either will need cauterizations like EPC for AV malformations that are present in the small bowel, or to proceed with angiography to close their feeding vessels. Another male patient, 52 years old, with obscure overt bleeding and recurrent melena. He performed an upper endoscopy and a colonoscopy that were not conclusive for the source of bleeding, and he has recurrent melena. 30 minutes after capsule introduction to the duodenum, expected to the mid-jejunal region, we found an annular circumferential mass with bizarre shaped villi. The mass was witnessed to bleed intermittently. This mass caused marked tight narrowing of the lumen so that the capsule was retained for the next 6 hours till it passed thereafter. But of course, the capsule didn't reach the cecum. And that's the mass. You can notice the narrowing of the lumen, the presence of blood, that's a normal villus pattern before, then the presence of that mass that was ulcerated, and at the same time, it looked tight and with marked stenosis, and the capsule didn't pass that lesion for 6 hours till it succeeded to pass later on. Then a male patient is 57 years old with recurrent hematemesis and melena, and he performed an upper endoscopy 7 times and the colonoscopy twice. And I was lucky, really lucky in that patient that I found the lesion was adulatory lesions was present in the stomach, and it was missed in the 7 upper endoscopies. As I mentioned, that was just the picture we saw. I referred this patient, and he performed an upper endoscopy, and with difficulty, the lesion was visualized. Then active bleeding was noticed, and a band ligation was performed for that patient. So capsule endoscopy ended his misery, and we diagnosed the lesion, and we managed the lesion thereafter according to the finding of the capsule endoscopy. Male patient, 50 years old, with severe anemia, hemoglobin 4.8 gram per deciliter, blood transfusion, over GI bleeding. Patient took chemotherapy and radiotherapy for previously resected malignant rectal polyp. Upper endoscopy and the colonoscopy thereafter were free. And surprisingly, this patient, I don't know how could it happen that he has a double malignancies, a previous rectal mass and another small bowel mass that proved thereafter with deep intubation with endoscopes and taking biopsy to be an adenocarcinoma, this one, with marked narrowing of the lumen, of course, again. Then the last case, a male patient, 53 years old, with obscure GI bleeding, anemia and repeated blood transfusion, and previous sessions of upper endoscopy and the polypectomy for polyps, not convincing as a source of bleeding, and he performed capsule endoscopy. And this one is a patient I had never seen before, such a number of angiodysplastic lesions like this one. He had first, second, third, fourth, fifth, seventh, and even in the single picture, in one picture like this one, we have 10 lesions of angiodysplastic lesions, and they were diagnosed only by capsule endoscopy. So finally, ending my presentation, it's important that good training, good preparation, and good focus for visualization are the main keys for an accurate diagnosis. And thank you very much.
Thank you so much, Professor Tamer. That was really very illustrative. And I thank you so much because you covered a lot of points, and the wonderful videos and illustrations really will let me tell you, hope you had more and more cases to show us. It was really very interesting.
Thank you, sir. It's a pleasure, sir.
And thank you for keeping on time. And now, Professor Afify and Professor Tamer, we will go through a discussion. And I will start by Professor Afify. There are some questions who came, most of them need a very fast, short answer. So the first one, what was the most common adverse event you saw in patients using osteoconumab? Infections were.
Yes, yeah, I used it not too much, and up till now, in the few cases I used the osteoconumab, I didn't find any side effects or serious infections or malignancy. In the literature, also there is no recorded cases of malignancy, but still the non-melanoma skin cancer, some few cases were reported on long-term use, but to the best of my knowledge, there are no common side effects.
Yes, but at least maybe it's very mild upper respiratory or nasopharyngitis, maybe few cases recorded, but the safety of this drug, you have illustrated that it has a very wide range. Another question is, when do you give your patient 8 weeks and when do you give them 12? And another part of the question is, when do you estimate?
I didn't hear you, Professor Sherif.
Yes, I'm sorry, Professor Afify. When do you decide giving your patients an injection every 8 weeks, after, of course, the loading dose? And when do you decide giving them every 12 weeks? Is there certain criteria you stratify your patients?
Yes. Yes. if your patient is biologically failed before or experienced failure of biologic therapy, it's better to give him every 8 weeks and not every 12 weeks. And if your patient profile from the start is a bad profile, he has a bad colitis, and he is presented with complication, it's better to give your patient every 8 weeks.
Okay, thank you so much. So you rely upon the prognostic criteria and the severity domains in deciding whether to give them 8 weeks or 12 weeks. But sometimes...
yes, and also the biologic experience also.
Thank you. But sometimes you start 8 weeks and then you escalate to 12. And maybe in some cases you may start 12 and you may have to go back to 8. Are there any criteria which makes you escalate or de-escalate?
I don't have an exact answer for this from the literature. When you will shift from 8 week to 12 week, and then when you shift from 12 week to 8 week, because until now the therapeutic drug monitoring for ustekinumab, I think it's not present commercially, because to shift and to decrease the frequency or increase the frequency from our experience in the anti-TNF is guided by this therapeutic drug monitoring. But here, I don't know if we have now a therapeutic drug monitoring for ustekinumab to target a level or not. But in my opinion, if your patient is showing delayed response at 16 weeks, I think to give your patient every 8 weeks it will be better. But this is not the guideline, just an opinion.
Yes, very nice. And it's according to the response of the patient. If you find your patient responding well for a long time, and he's in a very long remission, and you have started 8 weeks, maybe that time you will think of giving him every 12 weeks. And on the other hand, of course, every 12 weeks, and then you find the patient not showing a good response or going into more frequent remission, you may give him every 8. And this is also an opinion, as you said, it's a personal opinion rather than a guideline. So thank you for clarifying things, because a frequent question is, can you really stop a patient receiving ustekinumab? And you know quite well that if you stop, you have a chance of 50% of going into relapse. So do you think of this, or if a patient tells you or asks you, what do you answer or tell him?
As I said in my lecture, ustekinumab is used as a monotherapy. You don't use an immune modulator with ustekinumab. So if you stop ustekinumab, you will leave your patient without treatment. I think that's difficult. Sometimes with the anti-TNF and with an immunomodulator, you may think to stop if your patient is in a deep remission for 2 years. And then you can stop the biologic therapy and go on with the immune modulator. But if your drug is mono, I think it will be difficult, and I don't recommend that.
Thank you so much. And what about the risk of acquiring COVID-19 in patients receiving ustekinumab? Do you have any data? My own personal information is that it doesn't increase the risk of acquiring COVID. And in patients who have COVID, it proved that even using biologics could be protective against the cytokine storm. So what's your own impression or opinion, Professor?
My own impression, if your patient is taking ustekinumab, I think he must be vaccinated if the vaccine is available. He must take all the protective measures. He must not stop ustekinumab. And I think the possibility to have COVID in particular because of ustekinumab is minimal.
Thank you so much, Professor Afify. You're making things very clear, and you're throwing light about really the safety of this medicine. And you have emphasized that it is a drug having very low immunogenicity, giving us the advantage of using it for a long time without failing the response in patients who have response, of course. But sometimes you may get, let's say, an unsatisfactory response. In such patients, how do you manage such patients?
Yes, that's a difficult question. What after ustekinumab? What after loss of response of ustekinumab? Especially if your patient took before the classic therapy and then took one biologic and then you give to him ustekinumab. What is after ustekinumab? This is a difficult question, but for sure, as you know, Professor Sherif, the pathophysiology of ulcerative colitis or inflammatory bowel disease is multifactorial, and even the inflammatory cascade, some patients doing well with anti-TNF, some patients with anti-integrin, some patients with a different mechanism of action, the small molecules or the JAK inhibitors. So you will be obliged to give him another drug you don't give him before, working by another mechanism. So it may work at that time.
Thank you so much, because you're clarifying that patients on ustekinumab, when they fail ustekinumab, you can shift to another biological without the problem, and you find a good response to other medications. And also, we have to emphasize that failing response may be due to infection, may be due to albumin levels, may be due to other factors than the medication itself. So thank you so much for clarifying this point, especially that it's a frequently asked question by a lot of our patients. And now coming to our dear Professor Tamer, who gave us this journey through the intestine. And we have a lot of questions really for you, Tamer. I'm not sure that we are going to have a chance to answer them all, but really you have a lot of questions. So let's see how many of these can we answer. First of all, you kindly gave us the information that in patients with Crohn's disease, you have to do an MRI prior to doing the capsule endoscopy.
Yes.
Do you emphasize this? Because I'm going to tell you the case I already faced in a patient who had Crohn's disease, and his symptoms was he had real diarrhea. So I didn't expect that he had a stricture at all, and I gave him the capsule, and the capsule was impacted, and he had to do a surgical intervention. So kindly tell us to what extent you emphasize in doing an MRI in such patients prior to doing the capsule endoscopy. Please advise me.
Yes, sir. Actually, maybe more than 10 years ago, I faced a similar situation with a patient I didn't expect to have a Crohn's disease, and we asked, and he performed capsule endoscopy, and it was not impacted, but it stayed in the small bowel for a long time, that it ended visualization, and we are following using just an abdominal erect X-ray, and the capsule is radio opaque, so we can notice if it's still present or not, and after 3 days, it was still present, and then it came down. Every patient I am facing for chronic diarrhea and suspicious for Crohn's disease, I am asking for an MR or CT angiography first. And every patient with symptoms suggestive of pseudo-intestinal obstruction, the same I am asking for. I'm not asking at all for any patient for obscure GI bleeding due to active bleeding, for example, but for patients with chronic diarrhea, it's a must. They have to perform it before proceeding with capsule endoscopy.
Great. And you emphasize the importance in Crohn's disease. What about ulcerative colitis? And would the colonic capsule have a role in ulcerative colitis? What's your opinion?
Actually, no, sir. Ulcerative colitis, colonoscopy is easy for such patients, and in all cases, you are proceeding with biopsies for such patients and during follow-up. So it's not its role for ulcerative colitis. Even the colon capsule was manufactured for just one reason: increasing the compliance of patients for screening for colorectal cancer, and that's its job only. Otherwise, no role.
Thank you. Again, to the question of the MRI in a patient who had a retained capsule.
Yes.
Of course, MRI is contraindicated.
Yes. We do not perform MR after. I have to confirm that capsule endoscopy passed to the cecum. If it happened, no problem, it will pass in stools. If I ended visualization while the capsule is still in the ileum, I ask the patient to follow and to make sure that the capsule came out. Just because, of course, he can perform like a MRI or whatever procedure. Thereafter, it's not allowed that the capsule will be retained at the time. So I have to make sure if the patient, I am following patients who didn't show fecal images, I am following them till I'm making sure that they pass this capsule.
Perfect. The point is that MRI is contraindicated in
Yes.
patients who have the retained capsule. What about patients having pacemakers and defibrillators? Can we perform a capsule endoscopy in such patients?
I never did it. Some clinical trials tried at the first to do it, but ethically, I do not have the green light to do it. So no, I am not doing it.
Yeah, but there's no absolute contraindication for such. Is there any role for artificial intelligence in capsule endoscopy, Tamer?
Yes, in clinical trials, there are different lines of capsule endoscopy. Some of them are using contrast imaging, like the narrowband. Some of them are even doing motility disorders. Some of them are they try to take biopsies and to inject the drugs. They try to do capsule endoscopy that it looks like a mermaid. They call it even a mermaid capsule that is flowing and they controlling it in the lumen. So there are many trials, but actually, let's say that the main goal of the capsule endoscopy is the diagnosis of something missing in the small bowel. It's not its role up till now to use it as an interference or as a therapeutic maneuver. No, it's not its role up till now. There are all clinical trials, but up till now we are using it just for diagnosis.
Very good. That's very nice. One of the audiences is asking about the role of capsule endoscopy in diagnosing of celiac disease, because you presented one case showing.
I don't hear you.
It doesn't? Your answer is, Tamer?
Sorry, sir, I didn't hear it again.
What is the role of
I missed the question.
What's the role of capsule endoscopy in diagnosing celiac disease, if it has any role?
In diagnosing what, sir?
Celiac disease.
Celiac disease, yes. Of course, in celiac disease, the capsule endoscopy is suggesting the presence of a celiac disease because you have to take biopsy and you have to confirm the presence of villus atrophy. But it's a diagnostic picture, like us when we are doing an upper endoscopy and we are seeing scalloping and we are saying it looks like a celiac disease. Yes, the same. While performing capsule endoscopy, we are looking, we can say it's a celiac disease, and we are following patients with celiac who are not responding again for possibility of developing lymphoma. Such patients with celiac disease and not responding, they are performing capsule endoscopy.
Thank you so much, Tamer. And the last question is, in the era of COVID, the capsule is not an aerosol-producing procedure.
Yes.
So it's safe to do during the COVID. Do you
Yes.
think of using it more frequently, even for screening, for example, for viruses, or it's so expensive to avoid it in such an indication, although of its safeness and to be used in such a situation?
Yeah, actually, it's expensive, sir. And patients asking for capsule endoscopy for no indications we mentioned before, I am telling them actually that it will be expensive for them. They can proceed endoscopy totally safely without need for such expense.
Thank you so much. Really, we came to an end fast, and this was a very wonderful discussion from Professor Afify, Professor Tamer, and before Professor Mosli. Unfortunately, he left us, but it's time to thank you all for this wonderful day, wonderful meeting, which I personally enjoyed so much. I really thank you all. I thank also Jameson for sponsoring this, for Roya for this very, very active, and they did a lot of job, whether Dr. Nuran or Marwan, they made a lot of job to make this perfect. So thank you all, and hope we can meet again in further meetings very soon, and have a good night and a good weekend for all of you, and thank you, and bye-bye. See you.
نورت يا دكتور تامر.
نورتوا جميعا. السلام.
الله يخليك.
Thank you, sir. Thank you, sir. That's good.